Record. Awesome. Good afternoon, everyone. My name is Nicole Fernandez. I am the project manager of the Maternal and Infant Health Series at Wayside Recovery Center. And I would like to welcome you to our series this afternoon with Juliette Frazier. We will be hearing on the topic of leveraging technology to address maternal child health needs. I would like to just share that we will be recording the sessions. Our agenda for the day will be Juliette will share a presentation. You may hear from both staff members from United us who can answer any Q&A at the end. You're welcome to put your questions in the chat or the Q&A, and we should have, even though we're starting a little bit late, we should have time to answer those questions. And then if Juliette provides us with permission, we will definitely be able to share with you the PDF of the presentation that we ask you to keep for your use to review. If anyone has missed the session or you think it would be helpful, we do save the recordings on Wayside's Maternal Infant Health page, just as an education tool. And we will be offering CEU credits for this session today. So we'd like to welcome you to Wayside Recovery's Maternal Infant Health Series. Wayside Recovery understands that the maternal and infant health mortality crisis cannot be adequately addressed without understanding and dismantling racism and biases in our medical and behavioral health systems. We also understand that the complexities of the crisis require community-based responses. This means not only addressing the stigma associated with substance use disorders and mental illness, but also recognizing the inequities that persist across the behavioral health system. We owe it to the women and families we serve to play an active role in addressing healthcare gaps. With the support from the Minnesota Department of Human Services, DHS, Wayside is hosting these free public health echoes in this Project Echo series that focuses on fostering collaboration between patients, community and health practitioners to deliver high quality care to Black mothers and their families. This series is also supported by SAMHSA SOAR 2 grant, which is an opioid response grant. And with that, we are also sharing that Wayside nor SAMHSA or DHS is, promoting anything else during these series, and Juliette will share her disclosures. And so at this time, I'd just like to read a brief bio about Juliette so that we learn a little bit more about our speaker this afternoon. So Juliette is based in New Orleans, Louisiana. Juliette has earned her BA in history with a minor in biology from Loyola University in New Orleans. She also has a master's in public health and environmental health with a focus on disaster management from Tulane University in New Orleans. Prior to joining UNITA, she spent her career working for the local government in New Orleans and played a role in emergency operations during local disasters such as hurricanes and the COVID-19 testing and response. During that time, she ensured that the focus on maternal child health was present in those emergency policies and actionable steps were taken to protect those populations. Juliette's passion is to ensure that people specifically vulnerable communities receive the care and tools they need to flourish. She noticed that there is a gap in what local governments can provide. This passion led her to Unite Us. She is excited about seeing these gaps close and doors open by bringing community organizations together so people can receive the care they want and need. Without further ado, I'd like to present to you Juliette Frazier, who will be presenting on leveraging technology to address maternal child health needs. Thank you so much, Juliette, for joining us today. We look forward to hearing from you.
Thank you. Thank you, Nicole. It's nice to be here. and go ahead and share my screen. There we are. So good afternoon, everyone. My name is Juliette Frazier, and yes, today we'll be covering leveraging technology to address maternal child health needs. So just quickly, I just want to quickly go over what we'll be discussing today. So why we're coming together is to discuss the maternal health needs in the United States, as well as looking into Minnesota's maternal child health needs. And after discussing those, we're also going to get into some of the impacts of your work and how even if you directly impact maternal child health, work or do not directly impact maternal child health, work in public health often crosses sectors, so much so that your work probably does touch it in some way. And then finally, we're going to look at a solution together. So as Nicole mentioned, my name is Juliette Frazier. I am a community engagement manager with Unite Us, covering the Southeast region of Louisiana, which includes my home of New Orleans. And I saw that we have a fellow New Orleanian here. So hello. And then I also want to introduce Emily. Do you want to say hello, Emily?
Yes, thank you. Do you want me to just give my 20-second blurb about myself?
Yes, absolutely.
Perfect. So my name is Emily Gomez. I'm a senior community engagement manager that's based locally here in Minnesota. So I'm here to just help support any questions that you might have, being kind of the local person here, boots on the ground. But I'm really excited to hear Juliette share about her expertise in this realm. So thank you for having me.
Awesome. So if we're really interested in improving the health of those in the community, we can't just be thinking about clinical care. As many of you know, only 20% of a person's health is actually determined by the doctor's visits they go on, or trips to the hospital, or prescriptions that they receive. What we are addressing is not only how do we improve healthcare, but rather how do we improve overall health? How do we move upstream and address that other 80% or the social determinants of health? And we can do this by ensuring effective social care solutions at the individual level. We can in turn create healthier communities. These social determinants of health are social factors that affect a person's lifestyle. These are the conditions under which a person is born, grows, lives, works, and plays in. These things can range from education, economy, the healthcare system, social context, or environmental factors, just to name a few. And these factors are just as, if not as important, for the populations covered under maternal child health. So what is maternal child health? It is the health of women during pregnancy, childbirth, and postnatal period, according to the World Health Organization. So maternal child health covers a large range of ages, from childbearing age of someone identifying as female during the pregnancy journey, including the actual childbirth, and then the postnatal period, as well as the children up to age 5. In addition, it can also include the family members. So to summarize, maternal child health is focused area of population, except also it is extremely broad area of public health. But why is this important? The health and well-being of mothers and children can inform us of the health of the next generation, as well as predict the public health challenges for families, communities, and our healthcare system. So basically, it's the litmus test of the community health. Many factors can affect pregnancy and childbirth, including preconception health status, age, access to appropriate preconception, prenatal, and interconception healthcare, as well as poverty. And then infant and child healthcare are also influenced by social demographic and behavioral factors, including education, family income, breastfeeding, but are also linked to physical and mental health of their parents and caregivers. So, while we've discussed that maternal child health covers so many areas, I'd like to know a little bit about you. Where is your work or your expertise at? So feel free to choose more than one, or write in the chat box if other areas are not listed of your work. And you can annotate. I believe it should be the button next to maybe Q&A, I think. I can't hear you, Emily, if you're talking to me. I'm sorry.
Sorry. If you go to the top of the screen and click the drop down, it says view options. There's a little down arrow. You can click on that and then click annotate, and you can circle the areas in which your work supports.
Thank you. So education, family, child advocate. Great. Perfect. So I'm going to annotate for the person in the chat here. The point is, regardless of your exact field of work, since maternal child health is affected by so many areas, you're more than likely going to affect it directly or indirectly. So in summary, basically, we're all experts. Everyone here on this call has some sort of influence in maternal child health. Let me clear that. There we go. Despite major advances in medical care, critical threats to maternal, infant, and child health still exist in the United States. Babies of mothers who do not get prenatal care are 3 times more likely to have a low birth rate and 5 times more likely to die than those born to mothers who do get prenatal care. Additionally, approximately every 12 hours, a woman dies due to pregnancy-related complications. And outcomes are getting worse, and those outcomes are worsening by disparities. If you have seen the news lately, as in this last week, the latest report from CDC shows that 4 out of 5 pregnancy-related deaths in the US are preventable. Approximately 15% of women reported not receiving prenatal care as early as they had wished, accrediting that to healthcare barriers that they faced. Receiving early prenatal care can improve the outcomes of pregnancy for women, accrediting that to healthcare barriers they faced. However, if they do not know how to seek care or how to navigate it, it can become burdensome and taxing, while also facing other burdens. Investing in community-based care can reduce the incidence of low birth rate and prenatal births by 38 to 66% and 33 to 47%, respectively. In September 2020, March of Dimes released an updated report showing that 2.2 million women of childbearing age live in maternal care deserts, which are counties or parishes, if you're in New Orleans or Louisiana, without a hospital, birth center, or providers offering obstetric services. An additional 4.8 million women of childbearing age live in counties with limited access and maternal care. So each year, 150,000 babies are born to mothers living in maternity care deserts. The threat and reality of maternal mortality and morbidity is especially severe for women of color. Black mothers of all ages are 3 times more likely to die from pregnancy-related complications than their white peers. The rates of pregnancy-related deaths for Black and American Indian and Alaskan Native women over the age of 30 are 4 to 5 times higher than their white peers. And Black women are 27 more likely to experience severe pregnancy complications than white women. And these disparities cannot be explained by differences in age or education. Using the CDC data, maternal mortality rates among Black women with a completed college education or higher was still 1.6 times that maternal mortality was 1.6 times higher than that of their white women with less than a high school diploma. So how does Minnesota fare? Well, to be blunt and honest, it compares much better than the South or Louisiana. So I am by no means talking at you. But here are some of the highlights. There's a high prevalence of food sufficiency among children, a high prevalence of high-speed internet in households with children, and a high prevalence of adequate sleep among children, which is great. But only 77.4% of women in Minnesota receive prenatal care within their first trimester. This is also a health equity issue, as American Indian and African American Black mothers are less likely to receive adequate prenatal care as compared with non-Hispanic white women. And even if women have access to adequate prenatal care, many mothers, especially those living in rural areas, are at higher risk of complications during delivery due to delivering in maternal deserts, as described previously. Minnesota's infant mortality rate has declined by 29% since 1990, from a high of 7.2 deaths 1,000 births to its present level of 4.9 in 2021. And so while infant mortality rates for all racial groups in Minnesota have declined over time, disparities have remained constant for over 20 years. The infant mortality rate is over 2 times greater for infants born to African-American Black mothers and American Indian mothers than non-Hispanic white mothers in Minnesota. Black Minnesotans represent 13% of the birthing population, but made up for 23% of the associated births, pregnancy-associated deaths. American Indian Minnesotans represent 2% of the birthing population, but 8% of pregnancy-associated deaths. Most of the pregnancy-associated deaths occurred 6 weeks after the pregnancy to 1 year postpartum, which was 62.5. 20.8% occurred during pregnancy, and 16.7% occurred from birth to 42 days postpartum. Substance use was also identified as a leading cause or contributing factor in 31.3% of the pregnancy-related deaths. So as you described, so many factors and inequities are present in Minnesota and across the United States in general. So I'm curious, what inequities have you experienced personally or seen within your community that you think can impact maternal-child health? Feel free to put it in the chat box if you'd like. And knowing and seeing that some of you guys deal with substance misuse, I'm sure you have seen it plenty of times, and especially for the family and child care advocate. Lack of housing, yes. Lack of housing is sadly very big in many areas, including in Louisiana. Yes, high stress. Absolutely. Let's see. Oh, there we go. So what is a possible solution? According to the latest Minnesota maternal mortality report, it identified a significant need for focused services after delivery or the 4th trimester, which is where many Minnesotan pregnancy-associated deaths occur. Earlier and more frequent post-delivery follow-up care can help identify patients most at risk, including those with substance use or substance use disorder, and for those with other conditions, placing them at a higher risk of death by suicide. By removing structural and siloed dynamics and instead incorporating cross-collaboration, we can reduce missed opportunities for families to receive help and care. It's important to see the longitudinal record of what's occurring in each individual journey. So by using technologies such as Unite Us, you can connect birthing people and families to resources and support throughout their pregnancy and postnatal period to address other things such as food insecurity, housing, transportation, safety, mental health, substance use. This encourages cross-collaboration with providers and developing referral networks or communities of place to allow consultation on patients and help identify risky diagnosis in a timely fashion, instead of waiting for something to happen or for the individual to ask for help when it could be too late. By utilizing technology, we can see the impacts and needs that we have in the community. So for instance, we pulled the data within the Unite Minnesota team, and we can see the impacts that they've had to date for the state. We can see the top needs for Minnesota in the communities are food, housing, and individual family support, which is exactly what you mentioned in the chat as well. Drilling down on that data, we can see what happens when those needs are being sought and where there may be gaps in the community. So I'll give you guys time to think and read through these questions, but I'd like to hear your thoughts on health equity and what it means for you. What role does your organization help or improve? How does it help and improve health equities? And what opportunities do you see technology and how it can impact your work with working with individuals in the community? And I promise you, no answer or any answer is not a bad one.
We have a small group, so I'm gonna unmute people if that's okay with you, Juliette.
Absolutely.
Okay, so I'm gonna unmute and you can actually respond and ask your question if you like. I'm making my way down the list. If you would like to, here you go. I see Hazel has her hand up. Miss Mother Hazel, can you respond?
Yeah, I don't have one particular organization because I'm retired. I work with various organizations, and I'm a proponent for utilizing community health workers with families to help to navigate resources. I'm old school, so technology, I have problems with technology. I like hands-on people. So if technology can connect people to people and not another machine, I'm all for it. But I find that community health workers can be, and especially the postpartum, the fourth trimester, can be very important in maintaining contact with the family, as you mentioned before, but also help to reduce some of the stress, the housing, helping food resources. So, increasing the number of community health workers is my soapbox. Thanks.
No, that's absolutely correct and a great point. So as mentioned, I come from the community health world, so I completely agree. And I think for community health workers, having that touch point within the community is vital. Technology helps collaborate organizations together, but you still need that people touch aspect of it. I don't want to pressure anyone else, but if there is anything else, please let me know.
Michelle also shared in the chat that technology could make the support more accessible, which we certainly have seen in Minnesota and kind of across the United States as a whole, right? Being able to tap into statewide partners, organizations that maybe you aren't familiar with, before. So there's a lot of opportunity there, I would agree.
Thank you.
Christine also shared that that they have a postpartum depression support group that they call More Than the Blues that is offered at a community center. So certainly a really important impact here when we think about connection to community.
Yeah, that's amazing. I hadn't heard of a support group called that or like that. So thank you. So what is technology? It's able to not only help with coordination and collaboration, but it also has the ability to improve within and then beyond past your front doors. Technology is able to help support staff, increasing organizational efficiency, while also improving community health through reducing some of the inequities and barriers in community. So you can better understand your efficiency and effectiveness of your work and your organization by tracking standard data and operational metrics. You can streamline data and collection analysis to support grant development operations or other funding channels. You not only have documentation of those coming through your front doors, but you can also showcase the reach within your community. And you can boost your widespread impact of local partnerships on the community by uncovering gaps in areas of resources that overlap. Now we can see further together the needs of the community that we need to address in real time. So various organizations play a vital role in our community. It is not enough to give someone a piece of paper that points them in the direction of the nearest food pantry. One food box is not going to improve a person's overall health. Instead, we need to look at the problem more holistically and figure out how to solve the problem on all spectrums. For Unite Us, our approach is that together we can securely and compassionately connect families to services that they need. We're able to identify the needs of individuals and local communities and drill down and discover different areas of the community where social care and interventions aren't happening, but so strongly needed. We're able to identify individuals. And once we do that, we're able to ensure that they're enrolled into specific services that they need and an accountable network that can guarantee that they're achieving their outcomes. And in the same token, we can continue to serve these individuals until all of their social needs are met, such as co-occurring needs that aren't identified until later. These are organizations in this place are building referral networks, but they may not serve the entire community. So instead of giving individuals a sheet of paper or asking them to Google more information, we're providing that service in-house. And beyond that, we're consistently measuring and evaluating the impact of our networks to prove that the work we're doing is in fact working. Through data-driven results, we're proving that real time and effort and money should be spent on equally healthcare and social care if we truly want to achieve healthy communities. And finally, we're helping organizations as they look to invest back into the communities. We're spending tens of millions of dollars on healthcare in the US with not as much progress as we'd like. However, what we are seeing are states utilize funding in a different way and pushing that money towards social needs. So for example, in North Carolina, they're using 1115 waiver to allocate $650 million of their Medicaid budget to social interventions. We're seeing the CARES Act dollars being distributed to support rental and mortgage assistance. And the economic relationship between healthcare, government, and social care is the future of our space as we look for the whole person care. So with that, I open the doors for any questions or thoughts. Yes, Hazel.
I have a question in regards to when you're helping the client, are you helping them to become self-sufficient? I mean, because I know you're helping them getting their resources. Are you teaching them to fish or are you giving them the fish to eat?
Yeah, I think it goes a little bit of both ways. For me, I say I am teaching them how to fish or where to go fishing. So I am pointing them in the direction of the organization and setting them up for success. And then from there, it is on them to work with that organization. So a little bit of both.
Perfect. I mean, because in my journey here in Minnesota, we keep feeding people and not teaching them to become self-sufficient. Therefore, they stay tied to the system. So I like the idea because most people, as far as I'm concerned, we have 4 generations of adolescents, teaching other adolescents, as far as I'm concerned. So we have to teach you about coping skills. They didn't learn that back in the day in our community. You were taught that kind of stuff, but nowadays people say, I call it the Mickey D generation. You want everything now, don't know how to prepare for the future. So those things we got to teach.
Yeah. Yes. I think through the platform, for me, and Emily can go in far more depth, but you're able to see that client journey. So that client journey is shared. It's one client journey record shared through all organizations. So if we're seeing a trend or something happening with a particular individual where there are constantly needs for every winter, they need food assistance. Well, if I'm working with them and I'm seeing that, how can I address that before wintertime? How can I address that now, getting ahead of that issue? How can I teach them how to fish before we keep going through this cycle?
I was in a meeting yesterday, and Unitas was sharing about how they're collaborating with community partners and resources. I'm wondering if there's a space here now to kind of just share a little bit about how this organization is trying to impact health by connecting communities to resources.
Yeah, great question. I can take this one, Juliette, if that's helpful to speak to Minnesota specifically. So, yeah, I think one of the things that Unitas is really committed to is supporting the community organizations that are doing the work in the community that's ultimately improving health outcomes for individuals. And a lot of the work that we do is bridging the gap between healthcare and social care. So finding the opportunities to bring those groups together to understand kind of the shared space that we keep, to really keep elevating the important work that community organizations are doing that are ultimately, right, saving healthcare money by keeping people out of the emergency room, for example, right, and finding pathways to continue to provide, whether that's funding channels, helping with data to demonstrate the work and impact that organizations have on their communities, continuing to build those connections between organizations and healthcare organizations. And so I think we're relatively new here in Minnesota, but we're starting to see from some of the slides I think, Juliette shared, that positive impact that we are having on people in our communities. I also think a lot of the work that we do is driven by community. So understanding where that expertise and knowledge already lives. Right? We are a tool at the end of the day, a technology tool that's we believe so crucial to helping coordinate that work, but we really recognize and strive to recognize and acknowledge the expertise that each community organization brings to the table, and that we really do need to have all of those pieces together in order to move this work forward. Right? So where are those logical entry points for people expressing needs? Hazel, to your point, right? Community health workers are a perfect example of being that trusted person in the community where I may not feel comfortable walking into my local food pantry on my own, but if I'm working with a community health worker, I may feel safe enough to express food insecurity for the first time, right? So being able to build a network that has no wrong door for entry point for our Minnesotans and helping to bring all of these groups together is really the work that I think the Unite Minnesota team and Unitas as a whole is really focused on.
Thank you, Emily. And I know we had a lot more registrants for this session, but oftentimes things come up, right? And people will watch this in a recording. And I think it's really valuable for the other partners, right, that don't know that Unitas is filling this gap in community, saying we have the resources in the coordinated efforts of kind of sharing information. With the call yesterday too, talking about if you want to learn more about Unitas or what that kind of partnership or sharing information looks like, that opportunity is there. And so I'm just really glad that we kind of connected through community and to see and have you in this space, Juliette, as well as Emily, bringing this work to life and letting us know locally and then regionally how we can continue to work together, because information sharing is critical, and we know the role of the community health worker is critical, right? When to do those warm handoffs or actually know the person that we're connecting families to, or know the program, or having had speakers and things from those respective communities to be able to share the information and also how programs work. So thank you so much.
I wanted to also just highlight Christine shared a question in the chat, and Christine, by all means, unmute yourself as well. But she said, as a 33-year-old white woman with an advanced degree, it took happenstance for me to find out about an IUD. A 26-year-old parent of one of my students. Oh, okay, Christine can't unmute. A 26-year-old parent of one of my students who already had 6 kids came to school and said, my mama is trying really hard not to have another baby. So her question is, what do you think of promoting awareness of options for women to have a greater control over their reproductivity without being thought of as eugenics or racist?
I'm going to jump in here as a community engagement specialist, and even having worked with families. It depends on who you are in this scenario, right? Are you the teacher? Are you one of their healthcare? Are you a community healthcare worker working with this family? Because even though the child is sharing this, right, that's a very sensitive topic, right? And if not being invited in to that conversation, I'm not sure where you could enter in that, right? But if it was around the child coming to school, as we often know, saying, hey, we don't have a lot of food at home at night, and I like to have an extra snack, or, Miss Fernandez, my mom needs some help with food, and we've had children do that. That's a little different because you can easily pack that food or give a gift card to Target or Cub or Hy-Vee, and you're supporting that family in the short term, right? And I could send home a resource for food pantry, et cetera, and it's all in the transaction of the young person. But with a young child, sharing that intimate dialogue with their parent, I just personally don't know a way to enter in that conversation, not knowing the relationship that you have with the family, because I would wonder that it would be considered in such a way. And I don't know if anyone else would like to comment on that as well.
So to add, the second part of her question is, as a community, is there a lack of information out there?
Do you want to take a stab at that? You want me to continue? I don't want to take over.
No, you can, this is open.
So
Yeah.
I just think that in some respects, right, the first things that I'm thinking is who provides their health care, right? And it's Christine is saying I didn't address this as a teacher, but thought, what about the disparity, right? Definitely the disparity, but I'm just thinking about there are opportunities where we can engage with family. And there has been situations in my previous role where there would be a child who needed new glasses and mom couldn't get off work to get those glasses. That's an easier place where mom let us know she's inviting us into that conversation, right? To help provide those supports as a school, an extension of community. And I just think that in this respect, if mom didn't share it with me, then I wouldn't enter in. However, some schools, and particularly high schools, have information. Some of them have health clinics within the schools. They're particularly for the students, but they're also a bridge to community if families need it. And then there are any number of programs, just like participants in this Zoom today, that represent multiple organizations that are community organizations that are talking about reproductive health. And I think right now we need to be a little more sensitive too right now with Roe v. Wade and the climate of the country where people feel safe to go get those resources. So I think it is, yes, people know about some of the resources. Some of them may be a barrier to those resources. And then we also don't know their cultural beliefs, political beliefs, or religious beliefs. And so that's why I say it's best if people are invited into that conversation. And then that way you're able to not be perceived or even be, right, in a space that you're not invited into with another person.
Another thing I just wanted to add, you said that the parent had 6 kids, but we don't know what the relationship she had with her previous OBGYN, if they even shared information about reproductive health. Because that's a sensitive question for a lot of people, and maybe they were hesitant. We don't know the background, the backstory, and with her reproductive care.
And Mother Hazel raises a really important point. I just returned from a conference, and just like with healthcare, education, and many of the intersections of the social determinants of health, when we said, oh, wow, there's these services and you can go and you can get them, there's been a lot of harm that has occurred in community where people have gone to places or even to healthcare to receive care and service, and they got just the opposite. So I'm glad that Mother Hazel raised that question, right? And we also want to begin to empower community about going to where they feel safe to get care, making sure they're going and receiving the care that they need, how to advocate for themselves, how to feel safe to inquire. Because if you don't have relationship, and even if you are struggling in this, right, you're not going to share. And I believe Juliette was saying that earlier, even about when she showed the diagram talking about the journey. So one of the prevalent things that we have to understand is really to be more cognizant of how we show up in community as providers, practitioners, and how we're doing our work. It's not just, oh, we have resources to do the work, but how are you doing your work, and how are you showing up, and how are you connecting and meeting community where they are at whatever point in a continuum of education, resource, or understanding. And I think that if we continue to think about meeting people where they are, I think that's a really great place, and then to build capacity from there.
Yeah, I think that's an excellent point. And then one of the things that I've experienced in working in the community was also their health literacy. So do they, even though we're providing information, so let's say to your question, Christine, is there a lack of information? Well, there may not be a lack of information. They could have it, but do they understand it? Are the providers explaining it in a way that they can understand it and they can do something with it? Or, do I know about birth control options, but do I know how to get it? Do I know every step of the way of it? So this is a compounded issue that I think also was seen in some of the slides, that there is a big disparity in maternal health. So compounded, I can have the education for it, but do I completely understand all of the systems at place? And Ms. Hazel?
Yes, I just wanted to add, for those of us who work in this field, we think there's a lot of resources out there. But I think for me, I think commonly that we think people know when they don't know the resources. So I don't know how well people publicize this stuff. So again, there are advertisement in doctors' offices, grocery stores, places where beauty shops, for those resources are not there. People don't see it. So again, it's how much promotion are they doing for these resources? How well do people know about it? We can call 311, but we don't even know what to ask for if you call 311 or 411 for information. So I think we're doing a poor job of PSAs because in Minnesota and Minneapolis do have a lot of resources, but I dare say most people don't know where these resources exist, except for the staff that's working at them.
Yes, and I will also say that is why in some ways that it is important for organizations. So you do know some of the resources in your community. You do understand some of the systems. You may not know all of it, but you know some of them. And so that's why it's so important, at least in my opinion, to use technology in a way of connecting clients to other organizations in your community. So that way they're not alone in asking for assistance. They may walk into a food pantry and just happen to mention, I need specific meals for, I'm pre-diabetic, or so I need certain meals. And that food pantry person may not know the best services to connect them to care. In the same way, the doctor may be telling them they need to eat better. So there's this disconnect, but by working together and seeing that, you're able to work together to really improve the health outcome of a particular individual and client instead of them navigating it themselves.
That's exactly what I'm saying. As a public health person, is envision my diagrams I show stuff is like the spoke of a bicycle. The client is the center, and all the rest of the spokes that surround are resources. So anywhere along the continuum. So Christy, you brought up a good point. My thing is, so even at the food pantry, they should have resources when people come in, maybe neighborhood clinics or the food shelves, so any point that the clients stop, those places that have resources should also have a list of resources to navigate, to do a hands-off. So it shouldn't be up to the patient to try and find stuff. I mean, if they're going to these resources, I mean, out there, so even Goodwill, Salvation Army, all of them should be part of this seamless system for people getting the help that they need. That's my envision.
Hazel, I think you and I need to connect. It doesn't look like I can type my email, but I think Juliette has a slide that'll share it. And if you feel comfortable sharing your email address in the chat, Hazel, I'd love to connect with you after today.
Yeah, that was Christine mentioned something that struck me too. I love the new perspective that you've given us, Juliette, of recognizing that 80% of healthcare happens in community. I didn't really think about it like that, right? But growing up in Boston, in the inner city Boston, my family's from the Cape, but I grew up in Dorchester, and literally, what is it, maybe about a 5 to 6 mile radius was my dentist, my clinic. Like everything really happened there. You only went to the hospital, you went to the hospital when it was something bigger, but literally all my practitioners were there in community. And when I think again about the warm handoffs in community, and when I was another role working in a school, and I reached out to a local food shelf, it was holiday times. I knew there were high schoolers who were struggling, families were struggling. And it started with a few students, but then when I reached out to this food shelf that's in Uptown in Minneapolis, which is more an affluent community, but yet when I reached out to that person, her daughter went to the school and she was like, oh, Nicole, I will give you X, Y, and Z. And then throughout that year, she literally was our personal food shelf that she would ask us, what kinds of food do you need? What are you looking for? We have meat, we have eggs. And so it was just really a beautiful relationship. But had I just sent that family there, would they have gone to Uptown to get that food? Probably not. Would that student and those families been hungry? Yes, it's an affluent school. And it's a public school, but it's one of the more affluent schools. Would they have gotten what they needed? No. And the fact that it wasn't necessarily my role, but I've done this before. I was willing, yes, to be that conduit, right? To make that relationship, met for coffee. And through that, she supported us throughout the year. She even delivered food one time when I couldn't get it. And so those are the things that we have to be willing to do. I'm not saying everyone, right? Some people don't feel that way, that, that's their role. But whenever we can reach beyond and establish those relationships, I think it makes a world of difference also from those who are the providers and also those who are receiving, to be in the middle. And we were able to send thank you notes, taking it a step farther. So I just really think it's about us bringing our humanity to our work and modeling it for others, right? How we want families to be treated, how we want partners to be treated. And I just really feel like that's the community that Wayside is representative of, and trying to treat and meet women and families, birthing people where they are, and provide those resources. And again, I love to say I love this series and connecting with people like you, Juliette and Emily, because you're the new teacher and you give us new information and we're able to put it into operation, and then we begin to share that same resource with others.
Yeah, no, that was a beautiful point. We are a teacher, sure, and a tool, but I think to your point, Nicole, community health workers, those in the community are so vital. What you do, who you touch, your knowledge is so impactful to those in the community. So I thank you. I'm not in that work anymore, and it makes me sad. But it's very true. You have to have a humanitarian approach to it in some ways. For me, I was grant funded in the city government. So technically who I could work with was limited, but could I say no? No, I try to find my workaround. So for me, using Unitas was kind of that workaround. No, you're outside of my parish or my county lines. I can't quite work with you, but here's how I'm going to connect you to care. Here's how we're going to do this, instead of me trying to spin my wheels or get technically in trouble by trying to work outside of my grant parameters. This is how we're going to do this. But thank you, and to everyone. I'm sorry I'm not as familiar with Wayside and or what you do in Minnesota, but from the sounds of it and from me investigating and looking at your website is beautiful work. So thank you all.
Now, does anyone else have any other questions that you would like to share in the last few minutes before we go? Or you could share anything in these last few minutes with Juliette or Emily, or any question? Okay. Well, we are so grateful that you were able to join us today. For me, it feels like a new beginning every time we do one of these sessions. We come together in new ways, and we think about how can we address maternal health, reducing the disparities, improving outcomes. It does take a village, and COVID has taught us that our village is bigger than we thought it was. And so we have really been a benefit recipient of hearing from people around the country and learning about so many organizations. So I just want to thank you both. Emily, I know we're going to stay in contact and be working together and collaborating and trying to bring other people under the umbrella of connection and community. And Juliette, even though you're in New Orleans, there's some amazing people down there doing some great work. Dr. Cerisi West at Tulane has presented for us. And so I'm looking forward to a conference or anything where we can get down to New Orleans and connect and see some of the great work happening there. So thank you all for attending, and have a great afternoon.
Thank you.
Thank you.
Stay safe. Eat a po' boy for me, Juliette.
You got it. Hazel, what's your favorite kind?
Oyster po' boy.
You're just like my mother. She loves an oyster po' boy. I'm a shrimp po' boy person.
That's my sister. And of course, you have to have the hot sausage.
Yes. Yeah, I only do that one on Mardi Gras